And the speaker is Dr. Fleisher from Borland Groover. I would call him a guru of IBD world. He doesn't need any formal introduction. And here's Mark.
Thank you very much. Hi, I'm Mark Fleisher. Thanks for coming out. I never like introductions because usually they're kind of self-serving and they're, I don't know, they're usually inaccurate. I always feel like it's a eulogy. You know, like they're going to say, here's Mark Fleisher, he was an ape's ape, defender of the faith. So our talk is going to be a little bit about inflammatory bowel disease, and this is a rare opportunity because it's not a talk that's sponsored by a drug company, and that's a problem. Drug company talks are promotional slide decks. Promotional. They're not educational. They're not fair and balanced. It's a promotion. You're being sold. I'm not trying to sell you anything today. The only thing I'm trying to sell you is how to approach your patient with inflammatory bowel disease. Simple as that. Those are our neighbors. This is what I think. This is what I know. And that's the title of the talk.
And the speaker is Dr. Fleisher from Borland Groover. I would call him a guru of IBD world. He doesn't need any formal introduction. And here's Mark.
Thank you very much. Hi, I'm Mark Fleisher. Thanks for coming out. I never like introductions because usually they're kind of self-serving and they're, I don't know, they're usually inaccurate. I always feel like it's a eulogy. You know, like they're going to say, here's Mark Fleisher, he was an ape's ape, defender of the faith. So our talk is going to be a little bit about inflammatory bowel disease, and this is a rare opportunity because it's not a talk that's sponsored by a drug company, and that's a problem. Drug company talks are promotional slide decks. Promotional. They're not educational. They're not fair and balanced. It's a promotion. You're being sold. I'm not trying to sell you anything today. The only thing I'm trying to sell you is how to approach your patient with inflammatory bowel disease. Simple as that. Those are our neighbors. This is what I think. This is what I know. And that's the title of the talk. I know what I think and I think what I know, which really is all about every subject in life, relationships, and it's just, this is what I think and I think what I know. But a little bit about me, okay, because a little bit. First, fourth grade was the height of my academic career. Those are the best grades I ever got in my life. That was the height of my academic career. And it's been downhill since then. Fourth grade, my mother was knitting and watching Merv Griffin, and Morty Gunty was on, and he was a stand-up comic. And it's fourth grade, and I said to my mother, you know, I think I'm funnier than him. And she said, well, maybe you are, Mark. Maybe you are. And I was lucky enough to, because it's a little bit about me, I was lucky enough to have written for The Tonight Show. And at one of the Christmas parties, I met Morty Gunty. And I said, oh my gosh, Mr. Gunty, you're the reason why I went into this. It's a long time ago. 1982 was my worst year. 1982 was when I was rejected by every medical school in our nation. Every school in the United States rejected me, which was all right because every girl at NYU also rejected me in 1982. So it was kind of a bad year. It was a bad year. Oh my gosh. And then 86 was my best year. 1986, I was accepted to the Sackler School of Medicine in Tel Aviv, Israel, and I got this thin letter. And oh my God, who wants to get a thin letter? So I got a thin letter and I opened it up and they say, congratulations, you've been accepted to the Sackler School of Medicine in Tel Aviv, Israel. And I got in my car and I rolled down my windows and I'm flying down the Belt Parkway and I passed by the Verrazano Bridge where a cop sits every day. And it's 40 years, he still is sitting there. And he pulls me over and he said, license and registration, please. And I gave him my license, registration, and my acceptance letter. And he said, what is this? And I said, that's my acceptance letter to medical school. And he said, well, I'm going to have to give you a ticket, doctor. And I said, oh my God, no one's ever called me that before. But boy, what a great year that was. Everything works out for a reason. I had medical school in Tel Aviv, Israel, and it was incredible. What a lucky moment for me. 2001, well, 2001 is 20 years ago, and I write that it's my defining year. It is. 2001, I remember when I got engaged, and I took Rhonda to the Twin Towers, and we laid down on the ground, and you could look up, and you could see the towers touch each other, and I miss them. But it's where I learned, it's where I stand with my neighbors, and I stand for my flag. I still get emotional about it, right? Oh my gosh. Right, just a little talk in Jacksonville, Florida, but can't help it. It's 20 years ago in September, and those are my phantom limbs. Okay, so let's get on. Let's make treating IBD great again. Now you know how I voted. My mistake was I only voted once. Who knew? Right? Imid. What's Imid? This is my world. Immune-mediated inflammatory disorders. It's a constellation of illnesses that are seemingly unrelated, but it's all the same thing. You have a rheumatologist and a dermatologist and a gastroenterologist, but really, we're immunologists. It's a constellation of illnesses where there's an overproduction of these cytokines that explode on the body, and they have nothing to fight except you. These cytokines are normally made to fight some sort of infection or inflammation, but instead, when there is nothing to fight, it fights you. So some people get several of these illnesses. Sometimes they're kind of overlapping. That's what we do. We do Imids. What are some Imids? Well, Imids are 3% of our nation has psoriasis, 2% has RA, 1% has IBD, 6% has an Imid. But that's why there's psoriatic arthritis, Crohn's arthropathy. They're overlapping. There's a higher incidence of psoriasis in patients who have Crohn's or ulcerative colitis. So if you ever notice the commercials, right, from the commercials outside, it's like 1 week they're selling it for psoriasis, and then the next week they're selling it for Crohn's. You know, it's like, wait a minute, because it's all the same illness. We keep giving these people these names of diseases. They have the same illness. It's an overproduction of cytokines. Huh. Wait a minute, I heard cytokines in the news recently. Oh, yeah, right. That virus that for sure didn't come from China, right? It came from Yuli, right? So that virus, yeah, it's from Yuli, right. There's a lot of bats in Yuli, right? So that virus, the reason why people are dropping dead is because of a cytokine storm. You know what we found out? Our little company. Well, it turns out that those patients who are on biologic agents who dampen their cytokine production are less likely to get an overwhelming infection with COVID. In fact, we're collecting data on people who are getting a biologic agent and anyone in their family who wasn't. And it turns out that we have several people who they're on a biologic, their spouse is not. They both run into the ER with fever, headache, cough. They're both COVID positive. The biologic patient goes home with ivermectin. The other one goes to the ICU. So don't be shocked. Don't be shocked if one of the treatments when someone rolls into the ER with active COVID is give them a shot of Remicade. Stop the cytokine storm. We were the first people in the country to say, don't stop the drug, it's okay. Because you get the gurus up there and they don't want to make any proclamation, they don't want to say anything. They're so busy saying nothing. And it's just been a waste of time. Like, give an opinion, say what you think. Know what you think what you know. Here's what I think, here's what I know. These drugs decrease cytokine storms. My patients who are on biologics don't succumb to this virus. Their spouses did. Huh. When you roll into an ER, I'm going to suggest in an article that we're going to try to publish that give them this drug and they'll go home, not in a box. Okay. I bet you didn't expect that. So inflammatory bowel disease. Inflammatory bowel disease is a spectrum of illnesses. There's Crohn's disease over here, there's ulcerative colitis over here. It's a spectrum of illness. When people say, he's got this, she's got that, oh my gosh, I roll my eyes so often, I'm sure I look like I'm post-ictal half the day. Right? Oh. There's a spectrum of illness. Because how do you define them? It's not so easy. They're not this or this. It's hard. Now, what are the signs and symptoms of inflammatory bowel disease? Very vague. Nausea, abdominal pain, cramping, unexplained weight loss, irregular bowel habits, sometimes joint pains. It's hard. It's hard. Work days lost. Work days lost. Average IBD patient, 16 work days lost. It's not IBS because there's lives lost. IBS, when an IBS patient comes into the office, I want to kill myself. However, when an IBD patient comes into the office, they may lose their life. There's a big difference. There's a big difference between IBS and IBD. But the overlap is hard to differentiate. And also, as a consequence of longstanding IBD, you can develop IBS. So it's hard when an IBD patient comes in. Is it active IBD, or is it a consequence of longstanding IBD that's been undertreated or underappreciated, and then now they're getting irrevocable consequences that leads to almost an IBS state? It's not so simple. All right, so how do we figure it out? Geography. Okay, so the GI tract. I love the GI tract. The GI tract, it's mouth, esophagus, stomach, duodenum, jejunum, ileum, colon, out. That's it, right? Not that complicated. Colon. Colon starts here by your right lower quadrant, goes up, across, down, around, and out. It's shaped like a question mark around the perimeter of your abdominal cavity. So Crohn's disease, once it leaves the colon, it can't be ulcerative colitis. Once it leaves the colon, by definition, it can't be ulcerative colitis. It can't be ulcerative colitis. Ulcerative colitis was actually first diagnosed and described in the British Journal of Medicine in 1956 by Truelove and Witt. Crohn's disease was first described in the New England Journal of Medicine in 1932 by Crohn, Ginsberg, and Oppenheim. And actually, it was defined by Ginsberg, who was the gastroenterologist, and Crohn was the surgeon. Oppenheim was the pathologist. But they listed articles in alphabetical order. So at the old Crohn's and Colitis Foundation meetings, Mrs. Crohn and Mrs. Oppenheim wouldn't sit next to each other because Mrs. Ginsberg was aggravated, and she wouldn't even show up. So the three of them were aggravated that they should have been naming it Ginsberg's disease instead of Crohn's disease. I mean, only the spouses and families would be upset about that. But Crohn was the surgeon, and it's 1932. By definition, Crohn's disease, it's anywhere. 40% is here, 30% is in your colon, 25% is mouth to ileum. Wait a minute, 40, 30, 25, that's 95%. 5% of Crohn's is purely extraintestinal. You do not have to have Crohn's disease in your GI tract. 5% is purely extraintestinal. Wow. You can get Crohn's in the skin. You can get Crohn's in your lungs, in your liver. You can get it anywhere. Crohn's is anywhere. 40, 30, 25, 5. Ulcerative colitis, by definition, is always in the rectum, ascends proximally, and never skips. So sometimes I see people, and they scope people, and the colon is inflamed, looks good. Inflamed, looks good. Inflamed, looks good. Well, Fleisher just said that it never skips, so that has to be Crohn's disease, and it can't be ulcerative colitis. No, because it's histology. So when you take biopsies of a colon, I don't care about the biopsies of the spot that looks red. Red is bad, I got that. So when it's red, normal, that's to my naked eye. But what I want to know is, what is the histology of the normal-looking area? Is there low-grade inflammation? So it's severe, low-grade, severe, low-grade. So ulcerative colitis can wax and wane within the same colon. So don't go by your eyes. And the reason why I realized that is because I was seeing a lot of people with Crohn's disease, and then all of a sudden I went to LensCrafter, I got better glasses, and now all of a sudden I'm seeing so many more things. So don't depend on your endoscopy. It's the histology. Serology, there are blood tests. There's ANCA, ASCA, OMC, CBIR1, myeloperoxidase. Oh my gosh, right? So someone comes in with ulcerative colitis, and the biopsies show that it's confluent disease. Low grade, low inflammation, bad. Low grade, bad. But it's all bad. So it's ulcerative colitis. But then their anti-neutrophil cytoplasmic antibody is negative. Their anti-Saccharomyces cerevisiae antibody is positive. Their outer membrane porin C is positive. Wait a minute, those last two, those are Crohn's markers. Maybe I better drop a capsule. Maybe there's something going on somewhere else. So you don't go with an upper GI small bowel follow-through because it's there are alpha errors and beta errors, false positive and false negative. So you don't want a false negative where you do an upper GI series and it looks okay because there's a high false negative rate in a small bowel follow-through. Oh, that's a waste of time. So there are MREs. Those are good. Capsules are the best. Capsules are where you swallow a camera the size of a NyQuil. You wear a battery pack on a belt. Now, the belt is not some nice little Coach belt. The belt makes you like this thick and you look like the Unabomber. So don't go to a bank. Right? So you wear this giant belt all day and then you bring us back the belt. We don't have to catch the camera coming out of your rear end. So thank God for that. But that's how you really define someone. As soon as someone says that they have ulcerative colitis and they're ASCA positive, I'm thinking, am I missing it somewhere else? And the last thing is genetics. There's NOD2 card 15. That's the marker for Crohn's disease. Soon, we'll be getting a lot more genetic markers. You know why? Because the real therapy is not in this room today. The real therapy is going to be gene therapy. That's where this is all headed. Where this is all headed is you drop a capsule, and the capsule is able to take a biopsy, a smart capsule. That's where it's headed. And your therapy is not going to be sitting in a chair in my infusion center. It's going to be gene therapy. That's the next step. I can't wait to see it. Tests. Tests are things we do to you. Treatments are things we do for you. Here's what I'm going to do to you. But the reason why I'm going to do these things to you is that I can give you things for you. How do you approach a drug? Thank goodness the reps are outside. Because now I can tell you what I really think without feeling uncomfortable. Right? So a therapeutic gain. A therapeutic gain is drug minus placebo. How well is a placebo? Oh my God, there was a guy in my group who retired, thank God. Anyway, there was a guy in the group and he loved giving Cipro and Flagyl for Crohn's disease because you know it works 80% of the time. Oh my God, I know. That's the Canadian Journal of Gastroenterology by Greenbloom. It's from 1980 and it's Cipro and Flagyl has a efficacy of 80%. However, in the same study, a Twinkie or Pez works 65%. That's the ultimate placebo. So it's 80 minus 65. So the therapeutic gain of antibiotic in Crohn's disease is 15%. So when the drug rep comes in and said, this works 80% of the time, that's exciting. How well did mashed potatoes work in the same study? That's the placebo rate. So it's absolute reduction of risk, therapeutic gain. And that's what you want to look at when they come into the office. How much better is this than nothing? Because nothing in any study is allowed to work 25 to 65% of the time. A 65% placebo rate is okay. That's an acceptable level in any study. If the study doesn't have a placebo arm, you're not interested. You have no interest in it. It's a waste of my time. You take the therapeutic gain, which is the absolute reduction of risk, which is drug minus placebo, and you get the reciprocal, and that is number needed to treat. How many people need to get this drug before somebody gets better? That's the number needed to treat. But don't forget number needed to harm. How many people need to get this drug before somebody is unhappy that they got it? So those are the numbers you want to look at. Number needed to treat, number needed to harm. Well, now it's time to make my case. I always think that I'm trying to make my case to the jury. That's what I think. I'm just trying to make my case. You may not agree with me, but I'm not going to talk just randomly and say numbers, right? There's always some guy who's, this worked 87% of the time, and you know they're just pulling the number out of their tush, right? There's a huge handout because of the things I say, it's what I know. I think what I know. So I want to corroborate my testimony to the jury. Okay, first, 5 ASA products. So it's Colazal, Acecol, mesalamine, balsalazide, all of them, Lialda, they all have equal efficacy, all of them. How effective are they? Not so great. It's a 25% therapeutic gain, only in the 25% that it's indicated for. Wait a minute. It's not indicated for anybody who's received steroids. It's not indicated for anybody who has small bowel disease. It's not indicated for anybody who has Crohn's disease. It's only 25% of your IBD patients are candidates for this set of drugs. And the therapeutic gain is 25% better than placebo. That's it. We used to think that, oh, even if it doesn't work, you continue it in ulcerative colitis because it'll decrease your risk for cancer. Because that's the elephant in the room. Am I going to get a tumor? Right? But it turns out that that's not the case. So you can get rid of it. It's a waste of time and a waste of money. You don't need it. therapeutic gain of 5-ASA products in people with small bowel disease is 0. The therapeutic gain of 5-ASA products in people who have received steroids in the past is 0. 0. Was I being obtuse? It's 0. Waste of time. And time, as I get older, is really important. It's really important. I was saying outside that I'm the older guy here, right, in my group. Right? There's only 2 older guys here, Colm and me, and the rest are all young guys. In fact, if you add up all the PSAs of all the young guys, it's still going to be less than mine. 5-ASA products. If you yell at your patient because they're not taking their drug that's ineffective, what are you talking about? How dare you not take that drug with no therapeutic gain? How dare you not waste your own time? I wrote that prescription. 0. Thankfully, Eddie Farrer doesn't know this. Okay. I can predict your future. That's what I love. This is a study by Pia Munkholm. Pia Munkholm, it's an old study. My God, it's from 1965. 65. Wow. This is old stuff. So what can I predict? As soon as I give an IBD patient, whether it's Crohn's or ulcerative colitis, as soon as I give them a steroid, I know what's going on. 20%, you're not going to respond. 36%, you're going to relapse in a year. 44%, you'll be okay for a year. Okay. Oh, wait a minute, what about in the second year? Oh my God, in the second year. Oh. So 20% don't respond, 36% relapse in a year, and of the 44% that were okay at year 1, half of those people relapse at year 2. So as soon as I give you prednisone, 40 milligrams every day for 4 weeks, drop by 5 milligrams every 2 weeks, you're going to feel better. You will feel better, most likely, because there are some people who are steroid refractory, 20%. But 80% you're going to feel better. I can give you crack and you'll feel better also. But you'll feel better, 8 out of 10. So what are your numbers? Once I give you prednisone, you have a 1 in 5 chance that you don't respond. You have a 3 in 5, or you have a 1 in 5 chance you'll be okay for 2 years. And 3 in 5, you're gonna flare. Those are your numbers. I can predict you. So as soon as you give that IBD patient, you have to be ready for the next step. What am I going to give you next? Because I know 8 out of 10, you're going to be a problem. Okay, so there's 6-MP, azathioprine, methotrexate. Methotrexate, those are vegan studies in Canada. And the reason why I dropped the names is so that you don't think I'm just talking. Oh my God, it's just Mark. Right? Like there are some times when I'm at dinner with Rhonda and the table next to me, some guy's pontificating, and I actually want to jump in and tell him, that's not true. But, you know, I can't do that with her there. Methotrexate, 25% therapeutic gain, but irreversible and irrevocable potential side effects of pulmonary fibrosis, not to mention bone marrow suppression, which are unpredictable. So I tend not to use methotrexate. That's number 1. Although I know the rheumatologists love giving methotrexate, but oh my gosh, I roll my eyes. Come on, guys. Come on. We got better stuff than that. Right? We got better stuff that's safer. Oh my gosh. Then, immunotherapy. Immunotherapy, that's 6-MP and azathioprine. So 6-MP is a pill, right? It's a pill, and it breaks down into 6-TG and 6-MMP. 6-TG is 6-thioguanine. Now that's the part of the pill that works. 6-MMP can kill your liver. So we actually check to see what your levels are every 6 months of 6-TG and 6-MMP. If you have too much 6-TG, you wipe out your bone marrow and you kill the guy. If you give them 6-MP and yet their MMP goes up, you just kill their liver. And we actually check their genotype. It's called TPMT. There's an enzyme that's a shunting enzyme that's switched between 6-TG and 6-MMP. And we check to see what type you have. If you're a 1-1, you can metabolize it safely. If you're a 1-3, you're going to kill that person. So 6-MP is a little complicated, huh? Oh my gosh. It's not just take a pill. And also it's weight-based. So it's 1.5 milligrams per kilogram in 6-MP. Azathioprine is 3 milligrams per kilogram. I see people come in and they're on like 1 granule of it, right? The person is, you know, a typical Jacksonville patient is 400 pounds, right? So they come in and they're on 50 milligrams of 6-MP. It's a weight-based drug. What are you talking about? Right? So you're already underdosing them. You have to follow their metabolite levels. And then how well does it work? It's only 35% therapeutic gain anyway. Oh my gosh. So it's pretty complicated. There's some downsides to it. And it's not that effective. What else? Oh boy, risk of lymphoma with 6-MP. Oh boy. The average person has a relative risk of 1, an IBD patient has 1.1. When you're on 6-MP, your risk of lymphoma is 4.4. Oh my God, you quadrupled their risk for cancer. Fleisher, you got something better? Sure. Sure I do. Okay. Now, stuff that works. Okay. Ulcerative colitis. These are all the drugs that are FDA approved for ulcerative colitis. It's funny because when these drugs came out, they weren't necessarily FDA approved. They just came on the market. And as soon as a drug comes on the market, it's up to you to decide what you think is a reasonable choice. For example, is prednisone FDA approved for treatment of inflammatory bowel disease? No. No, there's no FDA approval for steroids. And yet I give it like candy. So, you know, you can play the FDA game, like, well, it's not approved for that. It's like, all right, well, arrest me. I gave prednisone today. And if you'll notice, the font changes not because I don't know how to use the computer, and I'm just learning, by the way, but it's because it's the relative efficacies of those drugs. But ulcerative colitis isn't really ulcerative colitis. What's their ASCA? What's their Saccharomyces cerevisiae antibody? Like, have you missed their capsule? Did the biopsies look like ulcerative colitis? And it's confluent illness in the colon, and yet you missed the small bowel disease in the jejunum. Oops, sorry, wrong diagnosis. Crohn's disease. These are the Crohn's disease drugs that are FDA approved. And you'll notice, right, this is really nice. Remicade now. Now there are biosimilars. There are 2 biosimilars on the market. There's Absola and Inflectra. Absola is FDA approved, but it's never had any studies in inflammatory bowel disease. It's because it worked in another Imid. So it's not that I'm giving Absola a hard time because it was never studied in Crohn's or ulcerative colitis. It's just proving my point. Imids are all the same. We approved it in rheumatoid arthritis. We'll approve it in Crohn's and ulcerative colitis. Okay. They work just as well, by the way, and they're cheaper. I don't insist that my patient get Prilosec. You can take omeprazole. It's fine. You must take Protonics. You can take pantoprazole. It's fine. You must take Remicade. No. You can take Inflectra. It's fine. There were a couple of studies. One was from Kaiser, and then 2 other studies, and they show that you can switch from Remicade to Inflectra safely. That's one. There's another study that's head-to-head that you can, if you compare the efficacy of Remicade to Inflectra, they're the same. There's another study that shows that people who are on Remicade, and then all of a sudden the insurance company said, no, you got to give them omeprazole or Inflectra. It turns out that they can safely switch. So you can start them or switch them and not lose efficacy. Just so you know. So when you see the patients all of a sudden on Inflectra, it's not because the rep got me a nice new pen. Mechanism of action. Everybody hates this, right? Oh my gosh, everybody hates mechanism of action because this is truly when people go into REM, right, in the audience. It's right, mechanism of action is always so boring. So let's make it, here we go. You can do this. I know you can do this. Something aggravates the small intestine. Something aggravates the small intestine. And then lymphocytes are activated. The lymphocytes in the lymphoid tissue are activated. Something taps it on the shoulder and says, wake up. So the lymphocytes are activated. Then they're recruited. Come over here. We got a problem here. So they're activated, they're recruited. And then the lymphocytes, they pop out these buds, these Mickey Mouse ears, and those are called ligands. And the ligands are looking for a receptor. They find the receptor along the capillary wall. And they find the receptor, and the ligand meets the receptor, and then it goes inside the capillary wall. And then there's a cytokine storm. All these cytokines are made. And then whatever was bothering the colon or the intestine is wiped out. And then show's over. Move on. And the cascade stops. That's normal. Let's try it again. The normal reaction, something aggravates the small intestine. The lymphocyte is tapped on the shoulder, wake up, and it starts making some stuff with inside the cell itself. And then it says, come over here. So they're recruited. And they're recruited and more. And then these buds come out, these ligands. And they're looking for the right receptor at the bad spot. And they find that receptor and they hook up into that region. And my son told me I'm not supposed to say hook up, but I didn't realize that. So they link right? They link. And then there's a cytokine storm that is unleashed. And then these cytokines vanquish that foe. They kill that thing that shouldn't be there. And then when that inciting agent has been vanquished, the cytokines know to stop. There's no more waking up. There's no more recruitment. There's no more cascade. That's normal. Oh, but what happens in an Imid? Oh my gosh. Oh. So the lymphocytes are activated, they're recruited, they go to that region, the ligand meets the receptor, goes inside the capillary wall, a cytokine storm is unleashed, and the problem is vanquished. But they don't stop showing up. The lymphocytes keep getting recruited, they keep getting activated, they keep getting into the capillary wall. The cytokine storm keeps propagating itself. And so there's nothing to fight, so they fight you. That is an autoimmune illness. That's it. Okay. Oof, that's for me. Tell them I'll call them later. So, don't you love in the office when like someone's phone goes off, right? Like, by the way, your biopsy showed cancer. 1 minute. Oh, okay, I'll be home in a minute. Unbelievable. Of course, I respect you. There are a million different types of ligands. There's alpha-4, beta-7. That's the one that we really look for the most. That's the one that we look for, alpha-4, beta-7. That's the main ligand for lymphocytes interacting with that capillary wall. What about blood vessels? There's VCAM and MADCAM. We actually look for both of those receptors. We know how to find those receptors and block them. And then cytokines. Oh my gosh, I love this. This is tumor necrosis factor, and IL-12, 23, and 17, 6, 1, 2. It turns out the lower the number, the earlier it is in the cytokine pathway. The lower the number in that cytokine pathway, the more likely you're about to make that person immunosuppressed. So that's why we pick the higher numbers. It's further on in that cytokine cascade. But wait, there's more. JAK, right? Right is Janus kinase. Now it's getting complicated. There's JAK 1, 2, 3, type 2. What we try to do is we try to block the Janus kinase enzymes because that will in turn eventually block cytokine production. But it's not so simple. We try to block JAK1 because that's cytokines. But JAK3, oh boy, if you block that one, then what happens is you may get renal and bone marrow failure. Okay. So, you ever see like that thing about the JAK-STAT pathway? What does that mean? Well, come on, Mark. So much for this thing, huh? Hold on. Okay. Let's see if I can do this. Okay. STAT stands for signal transducers, which means that that lymphocyte is being tapped on the shoulder by some signal that's been sent from the area that's affected. Let's say I'm a lymphocyte. The problem is down there. The problem down there sent me a signal to wake up. So these JAK enzymes are involved in waking up the lymphocyte. And when you wake up the lymphocyte, you activate transcription. So there's a problem down there. It sent me a FedEx. Mark, wake up. So that's the first step. That's what a JAK kinase inhibitor does. It blocks that message from there into the cell to wake up. It lets it sleep. That's what those JAK inhibitors do. Okay. Then there's another option. There's like S1P receptor. That's the sphingosine receptor, and you see that in studies for multiple sclerosis. So this stops lymphocyte activation, but also lymphocytes being recruited. So it's really about lymphocyte aggregation. So the JAK pathway has to do with waking up the cells. The S1P sphingosine blocking modulators stop the lymphocytes from rolling along to that region. Okay, so what do? You stop lymphocyte activation. Basically, those drugs hit the snooze button. So that signal from over there telling me to start transcription and making all these things inside the cell before I start rolling out, that's stopping activation. And then stop recruitment. That's like a traffic cop. So one, it stops the message. One, pull over. Stop aggregating over there. And the last one is all these cytokines. It's a tree. So these drugs cut the branches of the tree. So it's go to sleep. Where are you going? I got to cut my tree. That's how all this stuff works. Okay. Now, you may not believe me because I don't know how to work the remote control. Right. Okay. So now, let's go back to that original pathway of how things work. And now we can talk about where things work. Here's where things work. First, something aggravates the small intestine, and then there's a signal sent, and that signal is mediated by JAK enzymes. That's where Xeljan works. Xeljan works by blocking the lymphocytes from being activated. Then lymphocytes are recruited and they aggregate in that area where they're needed, but then not needed anymore. That's where Zeposia works. That's a sphingosine modulator. So first it's a JAK modulator to wake up the cell. Then the cell is awakened, and then they're sent over inappropriately. So that's where Zeposia works. That's the sphingosine receptor. Then lymphocytes, they have Mickey Mouse ears. Those Mickey Mouse ears are ligands. It's alpha 4 beta 7, and they're looking for VCAM and MADCAM. And that area is blocked by Entyvio. That's where they work. And then if it gets through all of those other areas, and then the cytokine storm happens, boom! That's where the other biologics work. That's where Remicade, Humira, Cimzia, Simponi, all of those work there. Stelara works there also. The first group is on the anti-TNF level. The other is IL-12, 23, P40. So they're blocking these little cytokine branches. You know what I do before I pick a biologic? I check their TNF level. I check their IL-12 level. You can actually check the cytokine level. If someone's got Crohn's disease and their IL-12 is through the roof, why would I pick Remicade? That's Stelara. That's IL-12. If someone's TNF is through the roof, why would I pick Humira? Remicade is better. Why would I do that? Oh, and these people who are on Humira and it's not responding, and so instead of every other week, they give it every week? Why? That's the GAIN trial. There's no proof that increasing the dose of Humira frequency from every other week to every week shows any sort of efficacy. None. That's the GAIN trial. That's their own study, for God's sakes. Waste of time. Why do I make such a big issue? The next two slides. Only 2 drugs have been shown an increase in mortality in inflammatory bowel disease. Steroids and narcotics. Oh my gosh. Steroids and narcotics. When my patient asks me for a triplicate form, can I get some Dilaudid? And by the way, I've received Dilaudid, and I know why they want it. Wow. That is unbelievable. I'll take Dilaudid with my coffee cake every morning. I remember when Rhonda gave birth, right, and they gave her like a morphine pump, right? They gave her a morphine pump, and she said to me, "How Samuel?" And I thought, oh my God, she just had a stroke, right? Like Mr. Happy, right? Oh my God, how Samuel? And I said, what? How Samuel? Like I thought I just married Yosemite Sam. Suffering Thuckataff, how Samuel? And I said, have you been hitting that button? She said, it's amazing. Oh my God. You know what I did? I gave her the remote control. Same thing. She didn't know what she was hitting. I don't know. Keep changing the channel. Only 2 drugs have been associated with increased risk of suicide in inflammatory bowel disease. Suicide, increased risk. Steroids or narcotics. Okay, what about, oh my gosh, I see the CBD, right? I see all those CBD stores, right, which I always thought was the common bile duct. I didn't know there was so much biliary disease in Jacksonville. But I see these CBD stores. It turns out that studies are coming out also showing that there's an increased risk of suicide, increased risk of depression in people who are on marijuana. Oh my gosh. I don't know. If you need to reach for your narcotic or your marijuana, that means I didn't do my job yet. I need to make you drug-free. Except my drugs. Why does waste of time bother me? Well, it bothers me because I'm 60 years old, and I recently went to my doctor, and he actually asked me if I filled out my DNR form. I mean, oh my God, how insulting. Is it that bad? Time is tissue, and tissue is the issue. What does that mean, time is tissue? Because it turns out that the longer you have active disease, the more likely you are about to have an irrevocable, irreversible consequence from your illness. So inflammatory bowel disease has abscess forming, fistulizing, inflammatory, stricturing. The first three are reversible. The first three lead to the fourth, which is irreversible. A fistula is an abnormal tract. It's an off-ramp. You're going on I-95 and all of a sudden you take a ramp and the next thing you know you're at the town center, right? So that's a fistula. So that's one. I think Butler Boulevard is just a fistula, right? So that's one. And then inflammatory. Inflammatory, it's red, hot. Abscess forming, a pocket of pus. A pocket of pus in inflammatory bowel disease is not treated with antibiotics. It's actually treated with steroids. But wait a minute, I thought steroids for an abscess is not a good idea. Not in my office. You want that abscess to go away? That's Crohn's or ulcerative colitis. You give them steroids, it'll go away. That's what you give them. Antibiotics, 15% therapeutic gain. As opposed to 80% they're going to respond quickly, but 80% they're going to need it for 2 years, and then you're going to have to find something else. But you have to get them under control. You can't take someone to the OR with an abscess because they'll end up with a diverting ostomy bag. And then they'll hate you forever. And then you get 1 star on Yelp. I got a review, I got a 1 star on Yelp, right, from this person. So I looked them up, right? I wanted to see what else they reviewed, right? The week before, they actually gave Denny's 4 stars. My friends still talk about it, that I'm 1/4 as good as Denny's. Yikes. Talk about putting my ego in check. So time is tissue. The longer someone has active disease, the more likely they'll have an irreversible and irrevocable consequence. That's why I say stop wasting their time with 5-ASA products and, change your diet and take some ginkgo biloba or coumarin. I had a patient on coumarin. I honestly thought they said they were on cumin, which I said, oh my God, my wife puts that in the chili all the time. It's delicious. Come on. It's the therapeutic gain, number needed to treat. That's what this is about. Our job is not to pat stupidity on the back. It's to push them and let them be educated and empowered. Ignorance is not empowering. Ignorance is dangerous. We give them disease-modifying anti-rheumatologic drugs. Those are DMARDs. That's what we give them, right? They always talk about methotrexate as a DMARD. That's what I'm giving you. I'm giving you a disease-modifying anti-rheumatologic drug because time is tissue. The longer you have active inflammation, the more likely you'll have an irreversible consequence. And then no matter what drug I give you, it won't work because no drug works on fibrosis or stenosis. Earlier application of a biologic, less surgery, less hospitalization, less work days lost, less cancer. This is simple stuff. The earlier I give you a biologic, I can predict your future. It won't be as bad. Oh my God. I remember at a partners meeting once when I started here, oh my gosh, you see how painful that memory is, right? Like I have a good memory, but not all my memories are good. So this doctor, when Remicade first came out, he said, well, I don't like to give aggressive therapy. Oh my gosh, where's John Wilkes Booth when you need him? I was a former minor at New York University, and I'm a former English minor. I'm a double minor. My son was a double major, and he puts my nose in that every morning, by the way. But I was a double minor, English and Spanish. ¿Cómo estás? But nevertheless, I had a patient who came in, honestly, he came in and he said to me that, I said, do you have any dietary intolerance? He said, I don't do well with cheeses. And I was like, I'm sorry to hear that, but a lot of people do. He said, no, just cheeses don't agree with me. Anyway, so sometimes you have to have them write it out. Thank God I was a Spanish minor. Entonces, ¿no puede comer queso? No, I like queso. Oh, it really is a problem. Oh. So, when doctors use phrases like, I'm a conservative, I'm conventional, I'm old school. Old school, what do you mean? You have like a thatched hut with a water pump? How old school are you? Do you wear knickers? Does your hat, it has 3 corners? 3 corners has my hat? Come on. So if you want to use those kind of phrases, fine. Then you're archaic. You're morally indefensible. You're last century. Okay. Stick to science, not syntax. I don't want to hear that you're old school. Old school? I'm out of that office. I want someone who's new school. I want someone who's reading. I want someone who's reading PubMed literature searches all the time as their wife is calling them to come downstairs for dinner, for God's sakes. Right? Just one more article. I can't put it down. That's what I want. Before it becomes standard of care, I want someone who creates the standard of care. So you got to practice how many should be on a biologic. If you have 100 patients, 50% are going to be on steroids. If you have 100 IBD patients, 50 are on steroids. Of the 50 who are on steroids, you know that 80% of them, 80% are going to not respond or lose responsiveness within 2 years, which means 80% of those 50 people will be on a biologic, which means that 40 out of 100. So 40% of all your IBD patients should be on a biologic. And if you're not, well, then you better start thinking about what you're missing. 40% of all your IBD patients should be on a biologic. And if they're not, we have a problem here, Houston. Research. Why research? Oh my gosh, these are my two stories. It's my first day at Lenox Hill Hospital as I'm an intern. And Dr. Carlitz, who I'm so stupid, I don't even realize that he's the president of the American College of Gastroenterology. It's my first day out of the Sackler School of Medicine. I'm at Lenox Hill Hospital in Manhattan, and I can't believe it. I'm waiting by the elevator with him. And he said, well, Mark, what causes Crohn's? And I thought, oh my God, I don't know. And I said, I don't know. He said, okay. How do you cure it? And I thought, oh my God, I went to the worst school. Oh my God, I don't know. And he said, me neither. Let's figure it out. Oh my God, that's my first day as an intern. And I remembered Carol Salzberg lived across the street from me on Dakota Place. Carol and her sister, Michelle, were nuts, like all people from Brooklyn. Right? So she was nuts. But Carol was nuts because she was chronically on steroids for Crohn's disease. And at Carol's funeral, her mother said to me, Mark, you're a smart boy. Figure this out. That was twice in my life I was told, let's figure it out. I listened. Every day we try to figure it out. Every day. We're not just writing scripts. Actually, that's why you do research. Every day. Try and figure it out. So let's review. 1, I have a lot of emotional baggage that I need to work through. And I adore America. And 2, only a fool saves their big guns. But there's also one more fact. We are all in this together, and that truly defines us as a nation. And I love this place. And I love the fact that you were kind enough to come out and let me talk. Have a fun weekend. Thank you.
It's a great talk. Okay, so our next talk is colon cancer screening, the gold standard versus the other options. And the speaker is Dr. Jason Ross. Been with Borland Groover for almost 3 years. He earned his undergraduate degree from University of Texas at Austin, and also a doctorate in medicine from ETSU. He did his residency at Rutgers in New Jersey. And he's here to talk about colon cancer screening.
Good morning. Thanks for being here. I'm glad Dr. Tangella added a little bit more than what's in there, because I received an email asking if I wanted to add a little bit to my bio, and so all right, let's go. How do I get to the full screen?
That won't go to full screen. No, I think it's full screen over there.
Oh, okay. All right, so again, I'm Jason Ross. been Borland Groover about 3 years now. So first let's talk about the numbers. It's the third most common cancer in both men and women in the U.S., and men behind prostate and lung cancer, and women behind breast and lung cancer. It's the second most common cause of cancer mortality, only behind lung cancer. Last year, 150,000 new cases, 50,000 deaths, and the lifetime risk for average risk individuals about 1 in 25%. Non-modifiable risk factors: family history of colorectal cancer, family history of adenomas, family history of genetic syndromes like familial adenomatous polyposis, Lynch syndromes. They can cause other cancers as well: stomach cancers, endometrial cancers, brain tumors, ulcerative colitis, and Crohn's disease. And African Americans, we always screened at 45 because they were diagnosed at younger ages. But now the American College of American Cancer Society has changed their guidelines and recommend everybody get screened at 45 years. Modifiable risk factors: smoking, alcohol, obesity, diabetes, processed and red meats, and a sedentary lifestyle. Protective factors: physical activity, diets, fiber, folic acid, diets high in fish, and aspirin. And that's with a caveat. That's if your primary care physician recommends that you be on an aspirin, a low dose aspirin, if that will decrease your risk for cardiovascular event in the next 10 years. So we don't recommend everybody taking aspirin for colon cancer prevention. Just a little bit about the pathways for colon cancer. You have the adenoma carcinoma pathway, and then you can have the serrated polyp pathway. And then if you go a little bit more, you can have germline mutations, and those are the mutations in the syndromes, FAP, which affects the APC gene, and then Lynch syndrome, which affects the mismatch repair enzymes. And when you have mutations in those genes, you develop what's called microsatellite instabilities, and those are short segments of abnormal nucleotide bases that can occur for hundreds and hundreds of sequences at a time. And then you also have the MUT-Y associated polyposis, and that's a mutation in the base excision repair enzyme. So the screening guidelines. The American College of Gastroenterology came out with their new guidelines just this year. Last one was in 2009. So colonoscopy and FIT are the only ones that are recommended as the primary screening methods. Other screening modalities recommended for those unable to or unwilling to undergo colonoscopy or immunochemical testing. Other tests that we do: flexible sigmoidoscopy, CT colonography, stool DNA test, that's the Cologuard, and colon capsule. So average risk individuals. Average risk individuals are those between the ages of 50 and 75. Like I said, the American Cancer Society now recommending 45, people under the age of 45 begin their screening tests. And screening beyond 75 years old is individualized. So if you have someone comes in who's 80 years old, never had a polyp, never had no family history, their average risk, but you think their life expectancy is going to be another 8 to 10 years, then a colonoscopy is a low risk procedure. It's probably talking with the patient, benefits, risks. Consider proceeding with a colonoscopy or one of the screening tests that we can use. Increased risk individuals, those are individuals with colorectal cancer or advanced polyps in a first-degree relative at age 60 or younger, or 2 or more first-degree relatives at any age. And what do we mean by advanced polyps? Those are polyps that are larger than 1 centimeter, depending on what they look like under the microscope: tubulovillous adenomas, and those with dysplasia. Screening should start at 40 or 10 years before the youngest affected relative, whichever is earlier. Colonoscopy is the only appropriate screening modality for anyone considered increased risk. So if they have any increased risk, then no stool-based tests and no imaging-based tests. And if they do have a negative colonoscopy, these increased risk individuals should be screened every 5 years. So now we'll talk about the screening methods. So colonoscopy is the only, as gastroenterologists, we consider that the gold standard. It's both diagnostic and therapeutic. The big thing with patients getting them to do a colonoscopy is the bowel prep. It's the most annoying part of the conversation. The line I used to talk with patients is that I think we're going to have highways in the sky, society like the Jetsons, just this advanced society. We're never going to get around this. But it's because of the great screening tool we have. You talk with your patients that for those couple days, it's of being uncomfortable, which is really not that bad, is worth doing in the long run. It's done with sedation. We use propofol most of the time now. It's the best test available for seeing polyps, especially our flat and sessile polyps. It's the only test that allows for polyps and detecting polyps and for their removal. If adenomas are detected, endoscopy repeated in 3 to 5 years. Usually, if you have adenomas without any dysplasia, or if they're removed in pieces, then you're going to do it sooner. If the colonoscopy is negative, then you repeat in 10 years. That's if the prep is considered a good prep. Fecal immunochemical testing, it detects hemoglobin in the stool. If negative, it's repeated yearly. If positive, then you proceed with colonoscopy. Flexible sigmoidoscopy, colonoscope advance up to the splenic flexure. Less rigorous prep. We usually give a bottle of magnesium citrate and an enema. If polyps are detected, then a complete colonoscopy is required. You'll see that's a recurring theme here. Anything that's positive, you're going to go on to a optical colonoscopy anyway. If negative, then you're going to repeat in 5 years. This has really fallen out of favor just due to the increased incidence of right-sided colon polyps and cancers. So multi-target stool DNA test, the Cologuard, that we see a lot and order a lot these days. If it tests for mutations in advanced polyps and early colorectal cancers, it tests for KRAS and other hypermethylation hypermethylation of other promoter genes. The problem with Cologuard, first off, it has about 15% false positive rates, and when patients come into my office, all they know is a test for advanced DNA in advanced polyps and early colon cancer. So they really get worried. They're freaking out. And when they hear advanced colorectal cancer, rightfully so. And then so 15% false positive and 10% false negative rate. Another thing to consider is that if they do test positive for, if the Cologuard is positive, that changes their colonoscopy from a screening colonoscopy to a diagnostic colonoscopy. So insurance companies are going to look at that differently. That's going to affect out-of-pocket cost to patients, and in some patients, unfortunately, that might change their or affect their decision of whether they're going to proceed with a traditional colonoscopy or not. CT colonography, that's a virtual colonoscopy. So we take our patient and we inflate them with air, and we have them on their stomach, on their sides, and then we have our radiologists, take virtual images, 3D images, to detect polyps throughout the colon. It really depends on the size of the polyp. It's really not that great for detecting polyps less than 1 centimeter in size, and also it's very difficult to detect flat polyps. And with the high definition colonoscopes we have now, these flat serrated polyps are much more easily detectable using optical colonoscopy. Bowel prep is still required. It's uncomfortable for patients. They insert a rigid rectal tube and fill them with air. Polyp detection is highly variable. It depends on the image quality. If they still have a lot of liquid inside their colon, it's really going to affect the quality of the imaging, and also the size and the characteristic of the polyp, whether it's sessile versus pedunculated. Colon capsule, not really used that often. Swallow pill with camera, takes pictures of the colon. It's only approved for patients with previous incomplete colonoscopy, so whether they have a fixed colon, redundant looping colon. Bowel prep is still required, and studies are still being conducted to determine the diagnostic accuracy compared to other screening methods. So these are two important slides. I hope that's big enough. So this talks about sensitivity and specificity. So if you look at the FIT, 79% sensitivity and 94% specificity for colorectal cancer. The Cologuard, 92% sensitivity and 87% specificity, and we talked about those false positive and false negative rates that do occur. Septin 9, that's not even recommended. And then colonoscopy has a 100% detection rate for colorectal cancer, and reported incidence of post-colonoscopy colorectal cancer, 3 to 9%. Flexible sigmoidoscopy is very good at detecting those lesions in the left colon, and CT colonography. It has good sensitivity, but it depends on the type of polyp that is actually present. And that's it. I'm much shorter than Dr. Fleischer's, so I'm going to open it up to any questions. And I see Dr. Changela, he wants to move on.
I would like to emphasize
Yeah.
on the point that Dr. Rose made is when as a PCP, when you talk to your patient about Cologuard test, before you order, you have to tell them that if it comes positive, then you order a screening colonoscopy, but it's actually not a screening colonoscopy, it's going to be a diagnostic colonoscopy. So they should know this before they make the decision. And in 3 years with Borland Groover, I have a patient, actually she is an ICU nurse. She had a DNA-based stool test negative in 2020. We have the results, and she was unfortunately diagnosed with stage 4 colon cancer. So, a matter of fact, this patient, me and Dr. Ackerman, we share this patient. So that's my experience. I don't know if other doctors have any experience with that. And the second point I would make is when you guys take history in primary care clinic, make sure it's not only family history of colon cancer, it's also family history of, as Dr. Rose said, family history of advanced polyp also. Which
is tough.
Yeah.
I don't even know. I mean, you're asking patients if they know if their family members have polyps greater than a centimeter, what type of polyps they are. I don't even know what type of polyps.
So any family history, it is same considered as individual with higher risk. So this would go 10 years before or at the age of 40. It is still covered by insurance. Yeah. Any other question you have for Dr. Ross?
How often do you repeat screening in both first or second degree relative?
So if they have secondary relatives, you're going to start at 40 or 10 years younger than they were diagnosed. But then if that's negative, then you go to average risk. So every 10 years.
So every 10.
Yes.
I get mixed feedback from you guys about your hyperplastic polyps, and some of them I'll get 5 years recall with no other risk. Some I get 10. And so it makes us confused. It's been primary care.
So for whatever reason, they might be putting 5 years. Maybe it wasn't the perfect prep by guidelines, or maybe they
I read them,
and
they're all
it's good prep.
normal, hyperplastic polyp.
Yeah, guidelines are 10 years.
5 years.
Yeah.
Guidelines are 10 years, and sometimes if they have previous colonoscopies somewhere else which had polyps, so some GI doctors, even if they have history of polyp one times, they will, it's not the guideline, but they will keep them in 5-year cycle forever. But as you said, guidelines is 10 years.
And I have one of your colleagues had a 7-year. I've never heard of a 7-year follow-up.
I see a lot of it.
I know who you're talking about.
I go, if they say good prep, I'll go to 10 years. So that's what, yes.
Was there a basis of a 7-year
No.
follow-up?
No.
No. Yeah.
I mean, that's
I had a basis. I had a basis.
Yeah.
Because they like 7 years.
That's true. And we usually, if it's a good, I know Dr. Misra, I mean, he goes to 10 years. And so if you have any questions, you can, if that provider's, call one of the other providers and, talk to us as well.
Does the number of tubular adenoma increase the frequency of screening, say 1 versus 2?
Yes, so 1 to 2, they've changed the guidelines a little bit that, but I think most of us in the real world still stick to the old guidelines. 1 to 2 polyps, adenomas less than a centimeter, you're going to repeat in 5 years, and then 3 or more you're going to do in 3 years. Some of the guidelines say you can wait, with those numbers, 7 to 10 years if you have 1 to 2. But I think most of us are still on, practice on the conservative side. But the good thing is these polyps grow very slowly. Yes.
From the insurance side, what's considered diagnostic versus screening?
So diagnostics is someone who's having rectal bleeding, someone who's having abdominal pain, symptoms. Screening is they're just that age, they need a colonoscopy for colorectal cancer screening.
So in our practice, if somebody is due for their colonoscopy, and if they have some symptoms, we try to put it as a way of screening.
That's true.
Just to help that. Yeah.
Iron deficiency anemia is an indication for screening.
Absolutely.
But what about normocytic anemia? Is that an indication?
That's a good question. I would still do a colonoscopy. Is that an indication?
I mean, like, it won't be covered as a diagnostic colonoscopy because it's not iron deficiency anemia. Unless you have, like, some occult GI bleed positive, and even if it's normocytic anemia, it's still covered as a diagnostic colonoscopy. Yeah.
Yes.
Could you comment on, so when somebody does a screening colonoscopy and you find a polyp, does it turn into diagnostic coding and billing and things like that? How does that change?
So, I don't know the answer to that. Does it turn?
A lot of managed care companies have begun covering it. I think it was like 70% when we did an analysis was covered as a screening colonoscopy.
So if polyps were found, it's still considered a screening.
Yeah, it used to be that when a polyp was found and it was removed, that the patient's screening would change to diagnostic. But now it no longer does that.
And I guess the next or surveillance colonoscopy, that's considered diagnostic at that point, or is,
Surveillance?
yeah, that's
No, that should be,
that's still,
that's screening. Yes.
Is there a cheat sheet that gives you a summary of all this stuff?
yeah, the
I have one
ACG,
that's so old.
the ACG guidelines,
Okay, that's
March of
what I-
2021.
And if you go on up to date with colon cancer screening, there is like an algorithm,
Yeah, that's what I like.
and that's very up to date. You can just print it. Yes. Okay.
All right, appreciate it. Thank you.
All right.
70% when we did an analysis was covered as a screening colonoscopy. Not diagnostic.
So if polyps were found, it's still considered a screening.
Yeah, it used to be that when a polyp was found and it was removed, that the patient's screening would change to diagnostic. But now it no longer does that.
And I guess the next or surveillance colonoscopy, that's considered diagnostic at that point, or is,
Surveillance?
yeah, that's
No, that should be,
that's still,
that's screening. Yes.
Is there a cheat sheet that gives you a summary of all this stuff?
yeah, the
I have one
ACG,
that's so old.
the ACG guidelines,
Okay, that's
March of
what I like.
2021.
And if you go on up to date with colon cancer screening, there is like an algorithm,
Yeah, that's what I like.
and that's very up to date. You can just print it. Yes. Okay.
All right, appreciate it. Thank you.
All right. So our next speaker is from UFL Jacksonville, Dr. Shey. In 2018, he accepted an offer to establish neurogastroenterology program in the Division of Gastroenterology Hepatology at University of Florida. Jacksonville, within the last 18 months, he has established the largest motility center in Florida. He's going to discuss about GI manifestation of diabetes.
This is the pointer, and you can move the slides from here. Okay. And if you want to wear a mic.
Can you hear me, or do you need me to wear a mic?
You need to wear a mic.
Okay, let's call Mike. So my talk is about manifestations of diabetes in the GI tract. And my first slide is actually a bit more personal. I want to talk about our Dean, Leon Haley, that died tragically on Saturday. And his funeral is actually at this moment in Pittsburgh, started at 11. Leon was a very, very, very talented, intelligent person, highly motivated, gifted, a friend, and I don't think there's anyone who actually has anything bad to say about him. And he was on the verge of becoming really successful and probably moving to one of the Ivy League universities. But what he did to UF Jacksonville in the last 3 years was amazing. And on a personal basis, I also knew him. He was my neighbor. He was a guy you could talk to 24/7. You could talk to, and he'd remember, and he'd do. If you asked him for something, he'd do it. So, bye, Leon. GI manifestations of diabetes. Now, we know diabetes is common, and it constitutes a large medical burden for healthcare. Over 10% of the American population have diabetes. Most of it, of course, is type 2. Leading cause for blindness, renal failure, and non-traumatic amputations. And the GI symptoms and dysfunctions are highly prevalent, under-recognized, and associated with an impaired quality of life. As you can see, the prevalence, the incidence and prevalence of diabetes just goes with the population, increases with the population's age. Now, studies have failed to really evaluate and compare the frequency and type of symptoms among type 1 and type 2 and differentiate between them, although there is a tendency for type 1 to be more at a younger age and probably more serious at a younger age. And of course, what we look for is the diabetic triopathy and mainly the gastroenteropathy. That's the one that affects all the GI organs. A couple of studies that have been done within the years have shown that almost between 60 to 80% of diabetic patients have at least one GI symptoms, as you can see here. The manifestations are, the mechanisms are usually neuropathy, microangiopathy, and of course the hyperglycemia, and with mediators of neuroendocrine imbalance, if it's C protein, amylin, GLP-1, and other modulators. The hypoglycemic state is not good for the GI tract. It causes dysrhythmia in the stomach, causes abnormal relaxation of muscles, decreased contractile amplitudes, and we know that hypoglycemia actually accelerates gastric emptying and could increase or decrease the transit time, hence increase the motility of objects. Now, there is actually a protocol that was used in the 60s and in the 70s of if patients would come with severe diabetic gastroparesis or other hypomotility symptoms attributed to diabetes, they would give them insulin therapy and 3 times a day put them in hypoglycemic shock. But since today we have a lot of Morgan and Morgan and Farah, I think this is something that we do not adopt anymore. If you see the association between the prevalence of GI symptoms and the perceived or self-perceived glycemic control, you can see that those that have a good glycemic control have way lower symptoms than those that poor or the average glycemic control. Let's start by the organs. We talk about the esophagus. Now we know that the main thing that we see in the esophageal, here you can see, where's the, which one is the laser?
I think that's not working, the laser.
Oh, the laser's not working. Okay. So I'll do this.
Even it doesn't pick up the arrows. So.
It doesn't pick up the arrows. Okay. Yay. So as you can see in the upper part, we can see normal esophageal manometry. We can see the upper part is where the upper sphincter is. And then you have the esophageal body and the lower sphincter. Now this is the upper, it looks very nice. You see the striatal muscle is the red, upper red, and the smooth muscle is the lower red. And you can see this very nice amplitude, this wave, like in Maui, going like this phenomenon. Here on the other side, and down there, you can see a diabetic patient, where you can see the wave is not that firm, and you can see that the pressures are not that high. And even if you look at the lower sphincter, you can see it's been almost totally open, which means that the diabetic patients might have a lot of abnormalities and motility in the esophagus. However, there's not always a good correlation between their diabetic status and how much the motility is affected. But we do know that the symptoms of chest pain, odynophagia, and dysphagia are the main symptoms that can give you all these problems. Why doesn't this? Okay. Mentioned that. Okay. And of course, as you can see here, the anxiety and depression is one of the major factors also that could affect the well-being, and in diabetic patients it is even more pronounced than in normal patients who are non-diabetic. Acid reflux, something very common in diabetics, and in neuropathic patients, actually this many times we have what we call the silent reflux, where they don't actually sense the acid reflux, but it's there. Interestingly enough, who was here with Scott Ackerman talk about esophageal cancer? So you know that, I don't know if you mentioned that, but 40%, first of all, esophageal cancer is one of the cancers that's, still going a bit up. And 40% of patients with newly diagnosed esophageal cancer never had a heartburn episode in their life. 40%. Which means that there is probably some problem with their sensation. Now, there was one cross study that showed that the high prevalence of diabetics in between them, but it was not, studies after that did not verify that. Asymptomatic GERD is always a problem, and if you have diabetic patients, talking about the primary cares, always make sure to ask them very well if they have any whatsoever indigestion systems or indigestion symptoms or things like that, and be very trigger happy to send them for evaluation. Esophageal candidiasis, common with diabetics, and of course we can treat them here. Now, as I mentioned, the diabetics, when it comes to the esophagus, may present with symptoms more pronounced or less pronounced, or may not be even asymptomatic, although they still have acid reflux. When we go to the stomach, gastroparesis is considered one of the mainstays of diabetes, and sometimes even also dumping, which I'll talk about in a minute just for a few seconds. So if we talk about the diabetic gastropathy, we talk about both disorders of the gastric electrical and motor activity, and delayed gastric emptying in the absence of any mechanical obstruction. Now, the spectrum of the symptoms can reflect any whatsoever abnormality, if it's epigastric pain, early satiety, nausea, vomiting, reflux symptoms, and what we call cytophobia. Good afternoon, Dr. DeMello. Thank you for arriving. Thank you for joining. You made my day. Thank you, Susan. So of course, there's a higher prevalence of gastroparesis in type 1, although type 2 is way more common, so we also see it there. And most of the patients will see actually the type 2s. The duration of glycemic control and the presence of an autonomic neuropathy is one of the major mainstays. And the mechanisms could be a vagal nerve injury, a loss of the pacemaker cells of the stomach, called the interstitial cells of Cajal, which actually go through all the GI system. Of course, the ischemic microangiopathy and the neurohormonal imbalance of nitric oxide, CGRP, and other things. Common medication that could cause gastroparesis, anticholinergic, TCAs, you name it. However, when we talk about the diabetics, we need to mention the exenatide, which is a GLP-1 mimetic, which is a common drug for diabetics. And what it does, and also the DPP-4 do the same, they slow the gastric emptying. However, in diabetics, the exenatide GLP-1 mimetic exacerbates gastroparesis significantly. And one of the trick of trades, when I get patients referred, diabetic patients with severe gastroparesis, and I see that they're taking exenatide, I tell the primary care or the endocrinologist to go to another family, and sometimes the symptoms improve dramatically just by doing that. So it's something that if you have primary care or anybody to treat diabetic patients, it's nice to remember. How do we evaluate gastroparesis? Physical examination, of course. We do labs, CBC, chem, we check for thyroid functions, and we have diagnostic tests. The main diagnostics that the gold standard is called the gastric emptying. The gastric emptying is actually a scintigraphic test that you can see here. And look on the left, the top left, you can see in the beginning all the food. We give them a specific meal with 270 calories, up to 320 calories, and it's with technetium-99, and we can see exactly, we do the gamma camera, and we can see from 0 to 4 hours, the normal is 90% excretion of the food from the stomach. Less than that means there's delayed excretion of food. You can see here the normal scintigraphy at 0, 1 hour, 2, 3, and 4, and you can see that at 4 hours, over 90%, almost 100% of the food is out of the stomach. This is a gastroparetic. First of all, you can see the expansion of the stomach is less pronounced than in the than in the normal, and there is of course lack of emptying. I could talk 2 hours about gastroparesis, but just a couple of things you need to know is that the gastric emptying study that I'm showing you, scintigraphy, might be tricky. First of all, not a lot of places do the scintigraphy. A lot of places use what we call the SMART pill, giving a pill like this, a capsule that the patient swallows, and we see how long it takes for it to, I think I have a slide here evaluating the motility of that, but and I'll talk about it in a minute, but the scintigraphy, gastroparesis, you have three main abnormalities. One is the lack of relaxation of the fundus once we swallow the food and it goes down, once it enters the swallows. Once it enters the stomach, if the stomach won't accommodate it, or will give you a hard time accommodating it, then you're going to get the nausea, you're going to get the early satiety, you're going to puke everything you eat. Second is the contractility of the stomach itself. You cannot contract appropriately, it contracts slower than usual, or it can contract even faster, but not in synchronicity. Third thing is the pyloric relaxation. If the pylorus does not relax appropriately, then the food can get stuck. However, what happens, let's think logically for a second, what happens if I have only a problem with accommodation, which means the patient will eat the 320 calorie meal and will feel bad, will be nauseated, and will puke a bit, but then the body of the stomach functions appropriately, and the pylorus is not that obstructed. So after 4 hours, he could have almost 90% out, because he puked a bit, and the rest went fine. But he does have gastroparesis because he has a severe lack of accommodation. However, the scintigraphy could be normal. That is why we have today a special digital program that we can actually phase by phase go and see exactly where the problem is. Because what you do is you send for a gastric emptying and you see the results, and within 4 hours, 90% evacuation, and they say everything is fine. But within the 4 hours, you need to see what's going on. So how do we treat? We kind of want to treat the whole three pathologies I told you in one certain way. So we start with small frequent meals, we avoid foods high in fat and fiber, and of course we need to supplement with some source of protein, not to make them malnourished. Then we have, here you can see the vomit center, it's called an area postrema, and you can see that the dopamine receptor, dopamine, NK1, and 5-HT3, if we try to increase them, you can see that they affect the vomit center, and the cannabinoid works exactly opposite. So the cannabinoid agonist will actually decrease nausea and vomiting. So the drugs that we could use are, of course, the regular compazine, the Benadryl, scopolamine, anticholinergic. You put a patch for 72 hours and you can feel like an astronaut, because that's what NASA, all the astronauts when they in NASA do the training, they have scopolamine patches on them. And the two main D2 antagonists that we use are the Reglan, and of course there is the domperidone. Now domperidone, I'm on the advisory board for the FDA, whether to approve domperidone for gastroparesis. Thus far it is not FDA approved, and the only way you can give it is if you apply for an investigational drug. It's called an IND. You apply for that IND, they give it to you, and then you have to monitor every patient. You have to every 2 months take bloods, you have to do an EKG every 2 months for the first year, then every 6 months for the next, until the end. So what we did is, in Temple, we had the largest gastroparesis center in probably the world. We took 115 patients, and we actually saw that we could improve their symptoms, and only 12% discontinued. The major side effects were headaches and lactation. Well, the reason it was increase in lactation is because 90% of our population were females. And only one patient had a prolonged QTC, which is the main problem with domperidone, it did prolonged QTC. So the next thing we did is took 246 patients that we heard on our data, and patients we saw in clinic, and we followed them up for up to 5 years. And we looked at their EKGs, looked at the changes of the QTC to see whether we get something that is significant change. And Justin Field was a resident, and now he is graduating as a fellow at NYU in Mount Sinai. We actually saw, and we published this, that there was non-significant changes in the QTC. And we, of course, had contacted all these 246 patients. We had full monitoring of them, and they're all still alive. And none of them had any major cardiac issue. Prokinetics, erythromycin could work on the motilin receptor. Relamorelin is a ghrelin agonist, which unfortunately has the company decided at this point to stop, although it's already in the market, to stop promoting it from financial reasons. I don't know why. And the Zelnorm and the prucalopride 5-HT4 agonists that also are in the market. Botox. Botox injecting, if somebody has a problem with a pylorus spasm, then what we do is we inject Botox. We can inject Botox in the pylorus and relax the pyloric sphincter, and by that allow food to be excreted appropriately. Studies in the beginning did not show any effect, any significant benefit if you inject saline there or you inject Botox in the pylorus, and that gave us a hard time with the FDA. However, when we looked at, when we analyzed the studies that were done in the past, including at Temple itself, we saw that we did not use enough Botox, and we picked the wrong milieu of patients. So if you inject, instead of 100 units, you inject 200 units, and females react better than males, and the younger are also, and the idiopathic and part of the diabetics are also considered good, then we can get up to 70% response to Botox injection, and usually between 6 months to a year we need to repeat it, just to, because eventually it gets absorbed and it loses its effect. G-poem is something that we've done at, unfortunately we're not doing it yet at UF, but I think Nieto does it here. He's done a couple, I think, Jose. And our Temple experience was 73% clinical response, average length of stay of 2.5 days, and it was mainly because we wanted them to stay, the patients felt good the same day even. What about gastric pacing? It's also something that today is quite popular, especially in the diabetics and part of the idiopathics. And we did a Temple in the year 120, 150, between 120 and 150 stimulators, and it also improves symptoms. Those who are refractory to any medical treatment, usually we give them a jejunal feeding tube. It's preferred over a TPN. Sometimes we can also do a GJ, which is a gastric and jejunal, and like this they could vent their stomach, open the stomach and vent out. Decompressive gastrostomy, short-acting insulin preparations, which is something that we don't do anymore, and near total gastrectomy was nothing better to offer to them. Of course, we need to remember that when we start refeeding these patients, they usually come malnourished. We need to be careful with the refeeding syndrome. Hypophosphatemia could be very dangerous. Dumping, we have the early and late. It's not that common in diabetics, but we see it sometimes. And what we do is, of course, we change the diet. We give them complex carbohydrates, decrease the amount of fluids during the meals. And if that doesn't help, we can give them acrobose, we can give them octreotide, and some dicyclomine anticholinergic agents. Most of them usually within this realm improve. What about the small intestine? Small intestine, the effects of the diabetes remain uncertain, and we only have small sample size studies, mainly because it's kind of hard to specify the small bowel motility per se as something on its own. Here you can see the antroduodenal manometry. On the left you can see the old system, and on the right you can see the high resolution. And in normal manometries, we're looking for what we call the migrating motor complex, which is the sweep that comes every 24 hours or even less, and sweeps everything that was left in our tract down. And of course, the diabetics don't have that. We need to see reaction once we give people food to see reactions and conversion between the fed motor and between the relaxed and the fed motor. And of course, we need to see also the contractions after a meal. Here is this, what we talked about, the smart pill, and this is the smart pill, and as you can see, it evaluates three things: the pH, the pressure, and the temperature, and also it goes through the whole gut system, and it excretes. Usually, it takes 5 days for it to finish the whole shebang, and we can get, as you can see from the left, this is the data we can get. What you see down there is the whole gut scintigraphy, which is, we do it, I don't know if Mayo does it here. I know Mayo Rochester does it. We do it now at Jack's, and we used to do it at Temple. That was where it was invented. It's what you do, you give the patient the gastroparesis meal with technetium, and then it's 300 mLs of water, which is actually indium 111, and the first day we do the gastric emptying, and then the patient goes home, comes day 2, day 3, day 4, and the gamma camera sees exactly how well the small bowel motility is and the colon motility, including differentiating the certain zones in the colon. It is non-invasive. I mean, you just drink it, but there's nothing, not like the capsule that has some kind of a foreign body in you. This is food and the indium and technetium. And after 4 days, we can see exactly the motility of the patients from mouth to anus. And I encourage all the primary care physicians to also, you can refer directly to whole gut scintigraphy at our nuclear med at UF. Celiac. We know that there is 3 to 8% of patients with diabetes type 1 will have also celiac. We know we're talking about autoimmune phenomena, that they share some HLA loci and some non-HLA susceptibility genes. Thus far, if you scope a diabetic patient for any reason whatsoever, take D2 biopsies. That's a recommendation. The peds at Wolfson, they screen for celiac in any diabetic kid. And thus far, the jury is out for us, and we at this point, there are no recommendations in the adult population to screen for in diabetic to screen for celiac. But once you're in there, take D2 biopsies. Of course, if the patient has a lot of diarrhea as a presenting symptom of one of the parts of the diabetes itself, then usually you guys do take TTG, IgA, things like that, and check it out. Small intestinal bacterial overgrowth, also from lack of motility, something that's common in diabetics. Up to 40-50% of diabetics will have it, and they will come with malabsorptive symptoms, a lot of bloating, abdominal pain, diarrhea, and usually it's easy to diagnose either with a lactulose breath test, or you can sample if you do a jejunal aspirate. Usually we treat them with rifaximin. That is the drug that's most effective. What about the colon? Colon erectile disorders, constipation, 60% diarrhea, 20% fecal incontinence. Let's start with the constipation. We know that there is, like I told you, there is slowing of the motility. So if it's in the stomach and the small bowel, also in the colon will have a slowing of the motility. One of the main things we see is the lack of the gastrocolic reflex. What is the gastrocolic reflex? You go to lunch, you eat lunch. 20-30 minutes after you eat, you feel that, I could maybe go to the toilet now, right? That's common. That's called the gastrocolic reflex. That is a reflex that when there's a fundic accommodation in the stomach, it immediately sends through a specific neurostimulator to the sigmoid colon to cause contractions. That's called gastrocolic. And sometimes with constipated patients, non-diabetic, one of the trick of trades is sometimes I tell them 30 minutes after you eat, go and sit in the toilet. If you don't feel anything, go and sit in the toilet. Surprisingly, it works. Diabetics don't have this reflex, and this is one of the things that one of the diagnostic, or you ask them 30-40 minutes after you eat, do you want to go to the toilet? No. I'm constipated. No. Well, you know that you might be dealing with some autonomic dysfunction. Very nice study done with giving neostigmine or metoclopramide showed that it actually increased the motor activity, suggesting that the smooth muscle function was actually intact, and the problem is the autonomic neuropathy. So how do we evaluate constipation? Again, we do it if we need to do a colonoscopy because we suspect something. How do we treat? We start giving dietary fiber, hydration, prucalopride, lubiprostol, and linaclotide are approved for constipation, and diabetics actually respond quite well to the prucalopride, the 5-HT4 agonist, because it also has effect on the stomach. And a biofeedback if they're severely constipated. And now 20% of diarrhea, it's happening quite quicker. Diarrhea, again, we need a comprehensive history to see that they don't take a high sorbitol or fructose or other laxatives. Remember, we had a delay in the intestinal transit caused small intestinal bacterial overgrowth, SIBO, methanogenetic flora, a lot of bloating, a lot of discomfort, and eventually you can also get diarrhea. We treat them with either cholestyramine, octreotide, clonidine, or other things out there. What about fecal incontinence? Long-standing diabetes, sympathetic neuropathy, low volume diarrhea, and sometimes we get anorectal dysfunction, weakness of the puborectalis, neuropathy also of the muscle, with some myopathy of the muscles, and patients could have lack of good holding down there of the internal and the external sphincter. Many females, usually those that have prolonged phase 2 delivery and have tears there, type 2, type 3 tears, when you're young, our muscle tonus is really good and can compensate for any abnormalities around you. But when you reach the age of 50, something like that, the whole muscle tonus starts relaxing. And that is when you get women that come with fecal incontinence or some seepage, and you actually see that the muscle tonus was compensating for the last 15, 20 years, and now it's already unable to do that. So the diabetic lady will come at the age of 40. The non-diabetic will come at 50, 55. Here you can see how we evaluate either colonoscopy if there's any suspicious, or we think of microscopic colitis or anything else. Anorectal manometry, we check the basal and squeeze pressures and see that they're low. And we do endoanal ultrasonography, and we can see the integrity of the muscles on the left, and you can see on the right. You can see here. You can see on the right there is the whole fragmentation of mainly the external sphincter, and of course the fecogram. Again, how do we treat that? Optimize glycemic control, anti-diarrhea. If it's obstetric cause, sometimes we might need surgical treatment. Bulk laxatives and toilet training and biofeedback also could help in controlling a bit about the symptoms. Sacral nerve stimulation has also been seen to be beneficial, especially if you have a combo of fecal and urinary incontinence. This was from the American Diabetes Association, the prevalence of the GI symptoms in diabetes and medications that could be associated with it. So I don't know how well you can see that, but we're talking about the reflux and talking about the dysphagia, which will be part of the diabetes itself. If we're talking about the nausea and vomiting, we talk about the GLP-1, part of the gastroparetics. And you can see here that there's actually all kinds of the meds of diabetic meds could sometimes affect also per se the motility. So it's very important for the diabetic patients to see exactly what they're taking. What about the hepatobiliary system? The gallbladder. We know that there is an increased prevalence of gallstones, 38% increased type 2 more than type 1. The mechanism is the impaired gallbladder emptying due to lack of motility. And the common findings, if we do a HIDA test or something, we will see an impaired ejection fraction of the gallbladder, decreased in response to a meal. If we give them cholecystokinin, which is a stimulator for gallbladder contraction, we will see the lack of response. And of course, we know that the more we're hyperglycemic, the more we will inhibit the gallbladder contractions. Saying all this, still today, prophylactic cholecystectomy is not advised in gastroparetic patients, in diabetic patients. What about NAFLD? We're talking about almost 70%. Hispanics more than African American and Caucasian. And usually we talk about the NASH, the steatohepatitis, as being more significant in progressing to cirrhosis than the NAFLD itself. insulin levels and insulin resistance are part of the contributor factors. And how we diagnose with transaminase is ultrasound and FibroScan, and we manage with lifestyle and diet, vitamin E, pyrrolidazole, pentoxifilin, some of the drugs that are out there that have been shown. Statins, jury is still out. And bariatric surgery for diabetes, and I put a question mark there, despite the fact that there are a lot of studies coming in the last year or two showing that Roux-en-Y improves diabetes dramatically and decreases insulin resistance and everything. Still, you need to cost and benefit to see how well you can control the diabetic patients. If you see that their BMI is over 40 and you cannot control them, or actually in diabetics, I think it's 36 is the magic number that will get insurance will approve, you can offer them. If there's nothing else to help them out, or you failed any other measures, then probably you can offer them the bariatric surgery with good results. Pancreatic insufficiency, the exocrine insufficiency in 50%. It's usually non-significant. If it does, you can give some pancreatic enzymes. Pancreatitis, the odds ratio for type 1 diabetes and type 2 diabetes, you can see the odds ratios of 2 and 3, more than the general population. Remember that those who take the GLP-1 agonists and the DP4 have a 6-fold increased risk of pancreatitis from the treatment itself. Pancreatic cancer, this is a bit tricky here, but the odds ratio are 2. Mainly because some of the first symptoms of pancreatic malignancy could be diabetes. So then and it could precede up to a year or even more prior to that. So you give the patient the label of diabetic when actually he has something else. But still, diabetic patients, we still consider that we need to monitor their hepatobiliary system, pancreatitis system. So in summary, diabetes can affect any organ in the GI tract. The GI manifestation can directly impair quality of life, associated with morbidity and mortality. And although symptoms may vary, treatment should be directed toward the specific pathophysiologic abnormality whenever possible. Thank you. Any questions? Any questions? What do you want? What do you want?
That was a great lecture, thank you. So I just had a question. We do a lot of endoflips. What do you think in the future? Do you think endoflip may be standard of care in terms of measurements and diagnostic evaluation for patients with gastroparesis or pyloric analysis?
Okay. Yes, and you know that. So why are you asking that question? You know that. Oh, you're trying to promote? Yes. The endoflip system, which I did not mention because it's not part of the lecture, is the new balloon, high-tech balloon that we have that we can put either in the lower sphincter in the esophagus or even go to the pyloric channel, and we can see the diameter and the distensibility of that sphincter, and we can see the integrity, we can see exactly what's going on there. And today every poem, you know what poem is, right, most of you? Right. So somebody said no. It's per-oral endoscopic myotomy. It's when you go with a scope, what used to be a Heller myotomy or things like that surgery. You go with a scope today and you build a tunnel and you go through that mucosal submucosal tunnel and you cut that muscle. Today it's becoming a mainstay, and today, for instance, achalasia patients, today I think that most of the patients can enjoy benefit from POEM without going to have a full-blown surgery. So every POEM that's done has to be done with an endoflip next to it. That is good practice, that the operator knows exactly when he starts what is the diameter and what is the distensibility, and when he finishes the procedure, to see the improvement in distensibility means he did a good job, and not wait after recovery, do a barium swallow, a barium, we have also it's called a barium column, and see that, did not improve that much. Like this you can know on the spot. So it's the same for the stomach also. G-POEM is very much becoming popular, and I think it will be very successful. Of course, I don't think Lakarani should do that. No, he's not good at that. But all the rest should really try. Any other questions? Okay, guys. enjoy life.
Okay, we'll break for lunch now. Come back in 45 minutes instead of 1 hour because we're running overtime a little bit. And lunch will be held in River Terrace 1, room 1, which is left outside this room and right at the end of the hall. And we'll see you back at like 1:05. Thank you.